We have just a few case presentations as promised. So, first case is a 52-year-old gentleman who had a right mid-back flank lesion for approximately 1 year. It was not caught early, 10 by 8 centimeters. History of diabetes mellitus, heart attack. Worked as an HVAC installer, no tobacco, moderate alcohol use. Had a wide local excision of his primary. Path revealed a nodular malignant melanoma that was about 9.5 by 4.5 centimeters, negative margins, 4 millimeters, positive perineural invasion, questionable lymphovascular space invasion, and it was a Clark level 5 and invaded the subcutaneous tissue. He subsequently had a PET scan that showed 2 nodes in the right axilla, and they measured up just under 4 centimeters and just under 3 centimeters, as well as additional subcentimeter nodes, and questionable inflammation versus persistent disease at the surgery site. Subsequently, an axillary dissection with a re-resection of the back that showed negative re-resection margins, but 7 out of 41 nodes in the axilla that were positive with extracapsular extension, BRAF V600 negative, and the largest was 2.2 centimeters. And this is PET scan showing the axillary nodes initially. So I would open up to the panel what their recommendation would be for adjuvant treatment, if any.
Well, this is really an oddball case. But there is no, beyond the interferon, there is no approved adjuvant therapy. So I would, and I'm not sure he'd fit into a clinical trial with the amount of disease that he had to begin with. Maybe he would, but your choices are very limited, and one option is just to monitor him, carefully and treat him when the disease shows up, which will probably show up in about a week or two. In 2015, if you showed up in your clinic like this, you really, with such a bulky disease, you really can say he's really incurable. Surgeon just start treating him with disease, treatment for metastatic disease, but that's not, I guess it's not the FDA-approved thing to do right now.
Can I make a comment?
Sure.
So I guess my initial gestalt about this case is that the patient had 2 operations and probably could have had 1. So if a lesion this big was seen in the office, a small biopsy could have been done to make the diagnosis, and with lymph nodes that big, may have been able to have been found on clinical evaluation. I'm not opposed to PET scanning for staging, but I do think in a patient like this, could have had 1 operation with the wide excision with reconstruction and an axillary lymph node dissection at 1 setting. So that'll be my commentary here. Not a criticism because I didn't examine the patient, but a commentary. And one comment I'd make is if this were my patient with that many nodes positive and with high-risk characteristics in the axilla, I might make a referral to radiation oncology to consider adjuvant radiation given the characteristics of the nodes. And I don't know if maybe you would comment on that part.
Well, yes, obviously I'm a radiation oncologist, and I'm presenting the cases, so there's a reason I've seen these patients. So definitely he is someone who I was referred to because of the extracapsular extension, the perineural invasion, and the bulky disease in the axilla. And certainly with a patient like this, you could consider treating the primary site as well as the nodal site. This was interesting for me because it was the contralateral axilla that was positive, which was atypical, but it came very close to midline on the back. And so that is what we did. Actually, I did not treat the primary site. And I chose not to treat the primary site due to the very large size of the lesion. And So treated the axilla after he, oh, and he also had a wound vac. I apologize. He had a wound vac as well, so I didn't want to irradiate an open wound. So irradiated the axilla alone. A few weeks later, as Dr. Sharfman predicted, he had widespread metastatic recurrence as well as recurrence at the primary site that was very bulky again. And he's currently going and very painful. So he's currently undergoing some palliative radiation, and he's going to start hopefully some immunochemotherapy. So, second case, a 79-year-old woman with recent 20-pound weight loss, past medical history relatively healthy, only anemia, osteoarthritis, GERD, no history of alcohol, 20-pack year history, quit 20 years prior, only worked in clerical roles. Current weight when she was seen was 60 pounds. So she had never weighed more than 80 pounds her entire life. She had an EGD that showed a lesion obstructing at the GE junction, that's annular. Had a biopsy consistent with melanoma, no history of any skin cancers, resected, no history of melanoma. Referred to dermatology, did not have any lesions identified. Had a PET scan that was negative except for the GE junction mass. And was felt not to be a surgical candidate and had definitive radiation, which opened up her esophagus, and she gained some weight, but subsequently had widely disseminated disease shortly thereafter again. What treatments would you recommend? Would this be someone that you might recommend going off FDA approval, NCCN guidelines, and treating initially with chemotherapy? I open it up to the panel.
Did you mention her BRAF mutation status?
It was not done at the time.
Okay.
This is from a little while ago.
Okay. So, I mean, when you see someone like this, I mean, all the patients with metastatic disease, you want to get their BRAF mutation status up front and know if that's going to be an option for you. If she had a BRAF mutation, I would start her on BRAF inhibition with dabrafenib and combined with the trametinib, and try and just get some tumor reduction, get her back in better shape, and then probably switch to immune therapy somewhere along the way. I am very concerned about giving the Nivo-Ipi combination in patients that are this ill. Okay, I mean, I don't know that she would survive if she got grade 4 colitis or grade 4 anything. So if I didn't have the BRAF, I would probably, I guess technically off-label, give her Nivo or Pembro as a single agent, depending how far from my office she lived, and give that a try.
Now, would you do that before any local therapy, or would you do that after, or
Well, she's already,
irrespective? I'm just asking at any point during her care.
well, if she came in to the office and she had this GE junction problem and you knew she had a BRAF mutation, you could give her the BRAF inhibitors and she'd be swallowing well within a few days, you know. But if you didn't have that option, you have to do something to open up the GE junction. And we didn't really talk about radiation and abscopal effects, but there is this literature, you know, if you give radiation and one of the immune therapies together, you may get an abscopal effect. There's no harm in giving the two together. So one could, you know, if she had disseminated disease and the GE junction problem, you could give radiation and Nivo at the same time, something like that. But just keep in mind, there's great things happening in melanoma, but the patients like this were not included in the trials. Her outlook is not great, you know. So, but she has a chance. You know, she does have a chance of going into remission. But this is a very ill patient that we don't really know the best thing to do for yet.
We'll move on to the next case. A 79-year-old man with an ulcerated lesion on the left lower leg. Past history of a melanoma excised 25 years prior from his back, treated with wide local excision and no adjuvant therapy at the time. After the leg lesion, he had a wide local excision with subsequent sentinel node dissection. Hath revealed a 2.5 centimeter tumor, nodular melanoma, 10 millimeters thickness, level 5, with initially positive margins and positive LVSI. He, again, had a second procedure, had clearance of the margins at that time, and well as 3 of 5 nodes positive, 1 left inguinal, 2 superficial inguinal femoral, largest is just over 2 centimeters, did not have a completion axillary dissection. So for a patient like this, what would you recommend after this level of therapy? I open it up to the entire panel.
We asked if there was staging done after this.
Yes, he had a PET scan that did not show any additional tumor.
So if I, as a non-surgeon, if I can just wrap up, I mean, so he still has a chance of being cured surgically. The chance is not great, but it's real. So I guess the question, I think the wide excision margin is adequate, but, you know, it looks like you would, I mean, maybe we'd consider doing an inguinal node dissection, getting more nodes out, if he really truly has no disease elsewhere.
So just for clarification, the 3 out of 5 is from the sentinel or from the?
From the sentinel.
Yeah, okay. So point is well taken. I agree. I think that given a negative PET in this situation, that the proper thing to do, both for local control as well as a chance for prolonged disease-free survival, would be to offer a completion lymph node dissection. I think given the nodes that are found, inguinal and femoral, that this would be a superficial and deep. So I would personally clear out the superficial and the iliac nodal basins. It's a pretty big operation, but I think if there is no current sign of other disease, that would be something to do. And again, I might consider adjuvant radiation in this setting, although I think radiating, and I'd like for you to comment on this, is radiating the iliac basin, I think carries a different set of risks than just radiating the inguinal or femoral regions.
Right. Just radiating the inguinal is going to have potentially much more lymphedema than radiating the iliacs. But you can also make the question, well, how far should the radiation fields extend? Because again, this is not something that's not that is well defined, and a person could argue that you have a deep inguinal and a superficial inguinal, and maybe we should include the next level up iliacs. I'm also going to ask, this is a patient with 25-year history of melanoma, what the recommended follow-up should be for someone like this who, 20 years ago, 15 years ago had a wide local excision, no adjuvant therapy.
Yeah, I mean, we advocate that every patient with melanoma should have follow-up for life. I mean, it's one of those things that you never know. We tell our patients we'd like to think that every year goes by, it's good news, but the risk of it coming back remains, it never goes to zero. So we recommend, for our follow-up plan, if once the patient's diagnosed with melanoma, we see the patient every 3 months if it was an invasive melanoma the first year, and then we move to every 6 months after that for the next 4 years. So it's 5 years of close follow-up. And then after that, we move to yearly. We really try to emphasize to the patients that they really still have to be alert, certainly at the scar area, and in addition for second primaries, because we definitely see melanoma patients develop a second melanoma.
So no different follow-up guidelines after 5 years between general population, which should have a skin check, and patients with a history of melanoma.
Right, for yearly skin checks, yeah.
Okay.
Can I just add, I just want to be clear, the audience is clear. So Dr. Kim is talking about dermatologic follow-up for this patient. And it's more controversial about what kind of oncologic follow-up one's going to do here. And the guidelines are all over the place. If you look at the NCCN guidelines, it's almost from nothing to PET scans yearly, and the answer is we don't know what kind of follow-up is really necessary. But I think what's different now is a few years ago you could be nihilistic and say, well, if it comes back, what are you going to do anyway? But now that we have, therapies actually work when we have a relapse, I think it's probably more important to identify recurrences early. So I'm kind of personally going back to doing PET scans at least yearly in patients, I think are at high risk for relapse and maybe more often. But it's a big unknown area right now.
Okay, so PET CT was negative, but actually this patient had a CT of his chest, abdomen, pelvis a few weeks later that showed several lesions throughout the rest of the body that were suspicious for pulmonary, hepatic, and lymphatic mets, as well as a 5.7 mass that arises from the body of the pancreas. And one of his liver lesions was biopsied, which was consistent with his melanoma primary. So I don't know what your experience is with rapid progression after sentinel dissection or false negatives with PET scans at your institutions.
I don't have a comment on that.
I think unfortunately, we've all probably seen cases of very, very rapid progression of disease, and that happens in melanoma sometimes. I don't necessarily think it's an issue of the PET not being sensitive enough to pick something up. I do think that we sometimes, unfortunately, see very rapid progression of disease. I wouldn't say it's in the norm, but I actually think in 2015 or any recent times that the PETs are very good, and if attention is paid to the source images of the CT scan feeding the PET, that with this kind of disease progression this quickly, that it probably wasn't really there. It would be hard to miss that much disease on a PET, I think. But
Okay. Moving on to our last case, we've got a 40-year-old woman with a 2.2 millimeter non-ulcerated melanoma on her lower back, treated with a wide local excision and sentinel node dissection in her left groin. It showed a 2.2 millimeter primary, 2 or 3 nodes positive, I'm sorry, 5 millimeter and 6 millimeters. Subsequent completion node dissection with none of 15 nodes positive, including Cloquet's node. So would you do any additional treatment for this lady, or would you have treated her differently?
this seems very appropriate to me. It's an intermediate thickness melanoma. A wide excision with a sentinel node biopsy was done. The biopsy demonstrated 2 involved sentinel nodes, and so a completion lymph node dissection seems indicated. The total node count here is 2 out of 18. Very extensive dissection, good work by the person doing the operation and by the pathologist, I think. I wouldn't do anything differently, and I don't think there's anything much else to offer from a surgical perspective. So, but real risk, kind of stage 3 disease.
Yeah, I mean, we definitely discussed with the patient she has a risk of relapse. So I also would emphasize the positive here, that if I'm reading this right, the one focus was 3 millimeters and 1 point. What is that supposed to be, really?
It should be 5 millimeters.
Okay. I mean, she does have a very reasonable chance of being a 5-year survivor, and I always would emphasize that. But she would be a candidate for, as far as on-label things, either the PEG interferon or intron, and she also would fit in. I think she would fit into the ECOG trial now that's coming up of interferon versus Pembro. She would not have fit into the IPI Nivo trial that was just completed because she wasn't advanced enough.
Okay, well, I want to thank our speakers again. Thank you for humoring me.